I'm a consultant gastroenterologist and inflammatory bowel disease specialist from King Abdulaziz University Hospital in Jeddah, Saudi Arabia. I'd like to start by thanking the scientific committee of Al-Azhar University um, meeting Division of Gastroenterology for inviting me to speak today on the topic of advances in treated target therapy in ulcerative colitis, endpoints, and new therapies. I hope you find the following presentation helpful and useful in your clinical practice. So to start, these are my disclosures. And the points I would like to discuss today are the following. I'll start by talking about ulcerative colitis treatment evolution, the concept of deep remission in terms of definition, advantages, and then touch on the new treat to target strategy, stride 2 updated guidelines, and then I'll dive into talking about new therapies for ulcerative colitis. So it is with no doubt that the treatment of inflammatory bowel disease in general has evolved significantly over the past 4 decades. As you can see, since 1970, the treatment has moved from focusing on symptom relief or clinical remission to more objective markers of evaluation, such as biochemical and endoscopic remission, in addition to cross-sectional imaging. Following this, there was the introduction of histological remission in addition to patient-reported outcomes. All ties into the approach of treat to target, which is recommended and endorsed by STRIDE or the International Organization of Inflammatory Bowel Disease. Now, there's multiple definitions that can be used for remission in IBD. In ulcerative colitis, it's usually a composite target combining both clinical remission and endoscopic remission. For example, in ulcerative colitis, clinical remission is defined generally as the resolution of rectal bleeding and diarrhea, and in addition to endoscopic remission, which is the resolution of friability and ulceration as judged by the Mayo endoscopic subscore. The question is, how deep shall we go with our targets, and moving from symptom assessment to endoscopy, and then histology, and finally to the proposed future target of molecular healing. Now, the definition of deep remission, which is an evolving definition, varies as you'll find in the literature. But the most objective definition that I found is the definition made by Joe Colombo in the digestive diseases in 2012, which was a state with little or no risk of disease progression, however that be defined. Now, mucosal healing and deep remission are very important targets in clinical practice, and mucosal healing is defined in many ways. As you can see, in Crohn's disease, for example, has been defined as absence of mucosal ulceration. Otherwise, it can be defined as a CDEIS less than 3, or a CDS of 0, or a SCS-CD of 0 to 2, or a SCS-CD of 0. And deep remission usually combines a CDAI score less than 150, in addition to the absence of mucosal ulceration, or a PGA of 0 plus SCS-CD of 0 to 2, or a CDA less than 150 and SCS-CD of 0. As you can see, these are very different definitions, and you can find them interchangeably used according to where it's reported. Now, for ulcerative colitis, as you know, there's discordance between endoscopy and histology when it comes to assessing disease activity. As you can see by this retrospective single-center study, almost 27% of patients who had endoscopically quiescent disease had documented histological activity, indicating that there might be a need for deeper levels of assessment and hopefully a deeper level of remission in the future. We also know that endoscopy is a very important method of evaluating disease activity, as endoscopic remission defined as a Mayo endoscopic score of 1 or less is associated with improved long-term outcomes in ulcerative colitis. And as you can see here, we have odds ratios summarizing how there's a favorable outcome with long-term clinical remission, colectomy-free rates at follow-up, long-term mucosal healing, and long-term steroid-free clinical remission. Additionally, we know that histological inflammation does increase the risk for colorectal cancer. In this meta-analysis, we can see when all these studies are compiled together and pooled, how the presence of histological activity in ulcerative colitis is associated with the development of colorectal neoplasia, and vice versa. Histologic healing can reduce that risk. We also have learned with the accumulating literature that histologic normalization is associated with relapse-free survival for patients with ulcerative colitis. And here is data presented from Scandinavia highlighting that association. Of course, histological remission and healing are evolving definitions which are becoming more and more important in the management of ulcerative colitis. But up till now, the definition of remission and healing for histology remains controversial. You can see here how using different scoring system for histological activity, such as the Gabot score, the new index of the whole robust histological index, and also the Nancy index, which are two very new and important endpoints, how the definition varies. For example, in histological remission of quiescent colitis, we can see definitions for Robarts histological index being either an RHI of 3 or less, as long as the minimum appropriate neutrophil score is 0 and neutrophil in the epithelium is 0. Where for the Nancy index, it is a Nancy index of 1 or less. Now, this all ties into the treat to target concept for ulcerative colitis, which is becoming the standard of care now while treating patients with UC. And it really is based on setting targets and timelines in addition to methods of assessment while following up these patients using this approach. And this has been associated with better outcomes, as currently recommended by several societies. For example, the STRIDE guidelines, which was published back in 2017, recommended for ulcerative colitis following the target of clinical remission, which is resolution of rectal bleeding and normalization of bowel habits, in addition to endoscopic remission, defined as a Mayo endoscopic subscore of 0, in addition to timelines for assessing these targets, which is 3 months for clinical remission until symptom resolution, then 6 to 12 months thereafter, and for endoscopy, 3 to 6 months after start of therapy for a patient with symptoms. Now, recently, there was an update, which is the STRIDE 2 for the previously published STRIDE 1 guidelines. Now, the STRIDE group has updated the 2015 first reported STRIDE recommendation and developed 13 updates and new recommendations for the treat to target strategy for both UC and Crohn's. Here, time to expected response, remission, and endoscopic healing with different treatments have been introduced for incorporating the treatment targets. What they added is clinical response and remission, as well as normalization of CRP as immediate and short-term targets, and reduction of fecal calprotectin as an acceptable range to an acceptable range has been added as a formal intermediate treatment target. Pediatric targets are reflected by different measuring scales, and the addition of restoration of normal growth were added as a formal treatment target for children, in addition to restoration of quality of life and absence of disability as a long-term target. Here are the survey results that were done by IOIBD to develop these guidelines. And as you can see on the right, there's a high level of agreement between those who were involved in this process. So we have clinical response is an immediate target. We have clinical response should be defined as in UC, decrease of at least 50% in PRO2, which is rectal bleeding of stool frequency, and in children, decrease in the Buchai score of at least 20 points. Now, clinical remission is an intermediate treatment target, and they recommended considering changing treatment if this target is not achieved. Now, clinical remission for a UC, again, defined by PRO2 of rectal bleeding equaling 0 and stool frequency score of 0, or a partial Mayo score of less than 3 and no score more than 1, and in children a Buchai score of less than 10 points. Of course, clinical response or remission are insufficient to be used as long-term treatment targets. Here, it tends toward the dependence on more objective markers of assessment. So for endoscopy, endoscopic healing is considered a long-term target. And again, we should consider changing treatment if this target is not achieved. Assessment of endoscopic healing can be achieved by signal endoscopy or colonoscopy. When not feasible, alternatives in Crohn's disease can be capsule endoscopy or balloon enteroscopy. Now, for UC, endoscopic healing should be measured by the Mayo endoscopic subscore of 0 or a UC-EIS of at least 1 point. Histologic remission, although evolving, is not a treatment target in either diseases. Nonetheless, in UC, it could be used as an adjunct to endoscopic remission to represent a deeper level of healing. For biomarkers, normalization of CRP to values under the upper limit of normal and fecal calprotectin to a range of 100 to 250 is an intermediate treatment target in both diseases. So this is the updated strategy, and as you can see, we can see the targets divided into short-term, intermediate, and long-term targets, with consideration of histologic healing for ulcerative colitis, but it is not considered a formal target. So this is the treatment approach for ulcerative colitis, which is till now a conventional step-up approach. You can see patients with mild disease receiving mostly aminosalicylates, oral or rectal, in addition to topical steroids. For moderate disease, we have aminosalicylates, immunosuppressives such as thiopurines, which is CM6MP and azathioprine, and if needed, courses of PO steroids, mainly for induction, of course. Now, for severe disease, although we used to have in the past only a few choices for drug classes, such as cyclosporin and anti-TNF inhibitors, now we're seeing more and more categories of drugs introduced for these types of patients. Now we'll start with the anti-cytokines, and mainly here we're talking about anti-interleukin-23 inhibitors. So we know that in IBD in general, there's an imbalance between pro-inflammatory and anti-inflammatory cytokines, which leads to a cascade of inflammatory process that highlights the disease pathogenesis. Interleukin-23, for example, is a pro-inflammatory cytokine that comprises 2 disulfide-linked subunits, which is the P40 and P19. Ustekinumab, which is a well-known medication now approved for both diseases, targets the P40 subunit. We have newer agents such as izilkumab and mirikizumab, which target the P19 subunit. Of course, we know of the unified phase 3 study in ulcerative colitis. Here I'm presenting a part of the study results, which highlights the outcome on the right, which is histoendoscopic mucosal healing, which was reached by close to half of the patients treated with ustekinumab 90 milligrams every 8 weeks. Now, if we talk about mirikizumab, as I mentioned, an anti-IL-23 targeting the P19 subunit, here is a study that demonstrated efficacy as well as tolerability during 12 weeks of induction, followed by additional 40 weeks of maintenance treatment in its phase 2 randomized trial in UC. As you can see, here we have the outcomes of week 12, and we can see that, again, close to half of the patient receiving this drug demonstrated histological healing at week 12. And here we're mainly talking about patients on the 200 milligram dosing. At week 52, we can see, again, patients on mirikizumab, 200 milligrams every 4 weeks, having very high percentages with regards to histologic remission, durable histologic remission, mucosal healing, and durable mucosal healing. And this is quite significant. Now, another category of drugs, which is those that target signaling. And here we're going to focus on the JAK inhibitor. Now, the drug tofacitinib is a well-known medication that is now approved for ulcerative colitis and is being widely used in clinical practice. There's other JAK inhibitors, which I'll be discussing in the upcoming few slides. Here we have the drug filgotinib. And filgotinib is a JAK1 inhibitor selectively. And as you can see in this study, patients in the Selection study, which is a phase 2b/3 double-blind randomized placebo-controlled trial, were included in 2 induction studies and 1 maintenance study. Here, the focus was on clinical remission as defined by the partial Mayo score. Now, at week 10, partial Mayo score remission was achieved in a greater proportion of patients who were biologic naive and biologic experienced, treated with filgotinib 200 milligram when compared to placebo. Differences between the filgotinib 200 milligram placebo group were observed as early as week 2 and higher in patients who were biologically naive. A higher proportion of patients who continued thereafter on filgotinib 200 milligram than those who switched to placebo in the maintenance study were in partial Mayo score remission 9 weeks after re-randomization. And during maintenance, the proportion of patients the partial Mayo score remission remained relatively stable among those who continue filgotinib 200 milligrams compared with patients who switched to placebo. Patients in remission were more likely to have an IBDQ score of 170 or higher, indicative of remission, than those not in remission at week 10 and week 58. Filgotinib 200 milligram induced partial Mayo score remission as early as week 2, and a higher proportion of patients who received filgotinib 200 milligram versus placebo were in the maintenance study were in the partial Mayo score remission at week 58. And patients in partial Mayo score remission reported better quality of life than those not in remission. So here we're talking about a different endpoint from the same study, which is corticosteroid-free remission, which is a very important endpoint in clinical practice. This is a post hoc analysis of the same study. Now, this is the design of the study. As you can see, a large number of patients, 1351 patients were randomized to filgotinib 200 milligrams once a day, filgotinib 100 milligram once a day, and placebo. Now, non-responders went on to open label, and responders were re-randomized or continued to take filgotinib 200 milligram once a day, 100 milligrams once a day, or placebo. The primary endpoint of the study was proportion of patients with endoscopic bleeding, stool frequency remission at week 10 and week 58. Now, filgotinib is a once-daily oral preferential Janus kinase 1 inhibitor in development for the treatment of IBD in general. Now, filgotinib for the treatment of moderate to severely active ulcerative colitis was evaluated in this study. Long-term use of corticosteroid, as we know, is associated with significant side effects, and the aim of the study, or this post hoc analysis of it, was to assess the corticosteroid-sparing effect of filgotinib in the Selection study. So patients who were 18 to 75 years old with moderate to severely active UC were randomized in a 2:2:1 ratio to receive oral filgotinib 100 milligram, filgotinib 200 milligram, or placebo once daily for up to 11 weeks, which is considered the induction part of the study. At week 11, filgotinib induction responders again were re-randomized in a 2:1 fashion to continue their induction filgotinib dose or to receive placebo as maintenance. Corticosteroid use was kept stable at week 14, at which point mandatory corticosteroid tapering occurred. Steroids could be resumed during the maintenance study. However, if this baseline steroid dose was exceeded, this was considered treatment failure. In this post hoc analysis, corticosteroid-free remission was defined as remission at week 58, which is endoscopic subscore of at least 1, rectal bleeding subscore of 0, and no more than 1 point decrease, at least 1 point decrease in stool frequency subscore to achieve 0 or 1 without systemic or localized corticosteroid use that was indicated for ulcerative colitis in the previous 1, 3, 6, and 8 months. So here are the results. Of course, the baseline characteristics of patients in the maintenance study were similar across treatment arms. Of the 92 patients receiving corticosteroid at maintenance baseline, which week 11 maintenance, week 0, who received filgotinib 200 milligrams during the maintenance study, we have 27% in remission at week 58 and had been continuously steroid-free for at least the previous 6 months. The proportion of corticosteroid-free remitters in the filgotinib 200 milligram group was consistently higher than placebo. In patients taking steroids at maintenance baseline who continued steroid use after baseline, lower median prednisone dosing was observed with filgotinib 200 milligram when compared to placebo throughout the maintenance study. Now, in selection, a total of 199 patients received filgotinib 200 milligram in the maintenance study, of whom 37.2% were in remission at week 58. Of these, 93.2% were continuously steroid-free for at least the previous 6 months, and that is reflected by the figure on the right. So in conclusion, in this post-hoc analysis of selection maintenance study data, filgotinib 200 milligram was effective in reducing and eliminating steroid use through to week 58 in patients with moderate to severely active UC. And the vast majority of patients taking filgotinib 200 milligram who were in remission at week 58 had not taken steroids in the previous 6 months. So this reflects how this drug is really effective in causing steroid sparing while maintaining remission. Now, 2 other molecules which are also considered JAK inhibitors are the oral ritlecitinib and brepocitinib. And this was studied in the Viprato umbrella study for moderate to severely active ulcerative colitis. So here we have 319 patients with moderate to severely active UC, inadequate or loss of response or intolerance to one of the following steroids, immunosuppressants, or biologic therapies. So this is a 32-week phase 2b induction and maintenance study. So we have 8 weeks of induction where patients randomized to either ritlecitinib, brepocitinib, or placebo. And then we have a maintenance phase, which is 24 weeks, where patients received either drug, provided that they were in remission, modified remission, endoscopic improvement. So here are the results of the study. During induction, on the left side, you can see that patients receiving ritlecitinib 200 milligrams, of those 34% had achieved the endpoint of remission with a very statistically significant p-value. And on the right side, similarly for brepocitinib, 23.4% of patients were in remission, again with a very statistically significant p-value. Now, with regards to endoscopic remission, we have statistically significant endpoints with a very nice alpha when compared to placebo for both doses for both drugs. So moving on to a different class of medications, we all know of the selective inhibition of gut inflammation theory, which resulted in the development of gut-selective agents such as vedolizumab or Entyvio, which is now being used as an induction and maintenance therapy for both moderate to severely active ulcerative colitis and Crohn's disease. There are other molecules that have been developed for or targeting this same pathway of inflammation and considered gut selective agents. So one of them is the AGM-300, which is an oral antagonist of the alpha-4 integrin. Of course, vedolizumab is an alpha-4 beta-7 inhibitor. Here, the drug primarily antagonizes the alpha-4 integrin. And here it was studied as an injection therapy for patients with moderately active ulcerative colitis in a phase 3 randomized double-blind placebo-controlled induction study. So this is an orally active small molecule antagonist of the alpha-4 subunit, as mentioned. And in this phase 3 study, we have 203 patients with moderately active ulcerative colitis, plus inadequate response or intolerance to 5-ASA, and moderately active endoscopic evidence at baseline. So we had first a run-in phase of 2 weeks of placebo, followed by induction with AGM-300, 160 milligrams, or placebo in a 1-to-1 randomization ratio. The drug or placebo were given 3 times daily for 8 weeks. Responders or remitters were allowed to receive AGM-300, 960 milligram again at the subsequent relapse in an open label fashion with a primary outcome of clinical response at week 8. So here we have the results of the study at week 8, and you can see statistically significant p-values for all endpoints of clinical response, remission, symptomatic remission, endoscopic improvement, and endoscopic remission with very nice alphas. So in summary, AGM-300 induced clinical response as well as endoscopic remission with good tolerability. So AGM-300 may become a novel therapeutic option for patients who had inadequate response or intolerance to oral 5-ASA. So here's a population of patients who did not receive neither immunosuppressives or biologics. Now, another agent, which is the etrolizumab, this is an anti-beta-7 monoclonal antibody that binds both alpha-4 beta-7 and alpha-E beta-7 integrins, and to inhibit both trafficking of immune cells into the gut and their inflammatory effect on the gut lining. So we had 2 identical multi-center placebo-controlled double-blind, double-dummy phase 3 study, the Hibiscus 1 and Hibiscus 2, where there was randomization of anti-TNF naive patients with moderate to severely active UC to sub-Q etrolizumab 105 milligram once every 4 weeks, compared to sub-Q adalimumab in the conventional dosing, or placebo in a 2-to-2-to-1 ratio. The primary endpoints of the study analyzed separately for the 2 studies was induction of remission at week 10 with etrolizumab compared to placebo and safety follow-up for 12 weeks. Here's the baseline characteristics of both cohorts, and you can see how treatment arms were well balanced across all variables. So here's the results of both Hibiscus 1 and 2. So the primary endpoint in Hibiscus 1, the primary endpoint of clinical remission at week 10 was met. Significantly more patients achieved remission at week 10 with etrolizumab, and the p-value was statistically significant at 0.0173. Here you can see 19.4% of patients receiving the active drug, met the primary endpoint or demonstrated primary endpoint compared to 6.9% of those who received placebo. Now, in Hibiscus 2, the primary endpoint of clinical remission at week 10 was not met. There was no difference in remission at week 10. As you can see, the p-value was non-significant at 0.1729. Here is a summary of all of the endpoints. And as you can see, when you pool both cohorts together, the p-values are not statistically significant looking at all of these endpoints. When you look at the safety summary, most advanced events were not serious and graded as 1 or 2. There were no new or unexpected safety signals detected. The percent of patients with at least 1 adverse event was comparable across all 3 arms and across both studies. 2 fatalities were reported, both occurred in the etrolizumab arm and were unrelated to the treatment. There was no confirmed PML cases in this study. So in conclusion, etrolizumab met the primary endpoint of remission at week 10 versus placebo in hibiscus 1, but not hibiscus 2. Etrolizumab induced endoscopic improvement and histological remission at week 10 versus placebo in a significant proportion of patients in hibiscus 1. In hibiscus 2, nominally statistically significant benefit of etrolizumab versus placebo and endoscopic remission was observed. Pooled analysis did not show superiority of etrolizumab over adalimumab for week 10 endpoints. Etrolizumab treatment was well tolerated in anti-TNF naive patients with moderate to severely active UC. Here's another study looking at etrolizumab, which is a phase 3 study, the Gardenia study. So here's a phase 3 randomized double-blind, double-dummy study that enrolled adult patients with moderate to severely active UC, defined as a Mayo Clinical total score of 6 to 12, with an endoscopy subscore of at least 2, a rectal bleeding subscore of at least 1, and a stool frequency subscore of at least 1, naive in patients who were naive to anti-TNFs. The study design, as you can see in the bottom, it's a superiority trial comparing etrolizumab 105 milligrams sub-Q every 4 weeks plus infliximab dummy IV versus infliximab IV in addition to etrolizumab dummy dosing. The primary endpoint of the study was both clinical response at week 10 and clinical remission at week 54. These are baseline characteristics. So through week 10, we have 95% of patients in the etrolizumab completed the study and almost 92% in the infliximab. Now, 47.7% of patients receiving etrolizumab completed the study at week 54, and 52% of the infliximab group completed the study at that time point. This is the primary endpoint of the study. As a result, you can see that etrolizumab was not superior to infliximab. Clinical response at week 10 and the clinical remission at week 52 were very similar between the two groups, with a non-significant p-value of 0.81. Here are some additional secondary endpoints, and as you can see, there's no statistically significant differences observed between the two drugs across all endpoints. With regards to safety, there is no safety signals reported or seen in comparison between the two groups. So in summary, or in conclusion, etrolizumab did not meet the primary endpoint for superiority against infliximab and clinical response at week 10 and clinical remission at week 54. Nominal significance was not observed between etrolizumab and infliximab for the key secondary endpoints. Etrolizumab treatment was well tolerated in anti-TNF naive patients with moderate to severely active UC. Most adverse events were not serious and graded as 1 or 2. Serious infections and GI infections were only numerically higher in the etrolizumab arm, although no new safety signals were identified. Now, finally, the final class of medication, which is the S1P1 inhibition. So we have the drug ozanimod, which is S1P1, S1P5 receptor modulator. There's also the drug estrasimod, which is an S1P1, S1P4, and S1P5 receptor modulator. There's also fingolimod, which is an S1P1, S1P3, S1P5 receptor modulator. S1P receptor modulator binding to S1 receptor results in reception, internalization, and degradation, thereby inhibiting the recruitment of lymphocytes. There's also some other effects of this receptor modulation, such as control of heart rate, angiogenesis, lymphocyte recruitment from lymphoid organs, neuron cell function, and S1P2 regulation of vascular tone. So here we have the True North study. So here we have the first data from this phase 3 study of ozanimod induction and maintenance treatment in UC. It's a phase 3 multicenter randomized double-blind placebo-controlled trial of ozanimod induction and maintenance for moderate to severely active UC. This is the design of the study. We have 2 cohorts, cohort 1 and 2. The second cohort is purely open label. In the first cohort, we have patients randomized to either placebo or ozanimod 1 milligram daily. We have a week 10 induction endpoint, and then responders to placebo continue to receive placebo responders to the drug are re-randomized to ozanimod or placebo. And then, sorry, again, reassessed at week 52, which is the maintenance endpoint. The primary endpoint of the study was the proportion of patients in clinical remission per the 3-component Mayo score. There were some key secondary endpoints, which is the proportion of patients with clinical response, endoscopic improvement, maintenance of clinical remission, steroid-free remission, mucosal healing, both endoscopy and histology, and durable clinical remission. So these are the baseline characteristics. Slightly more males receiving placebo, otherwise a very balanced distribution. So this is the week 10 or induction efficacy results. You can see the primary endpoint of clinical remission was met. 18.4% of patients receiving the drug demonstrated this endpoint, compared to 6% of patients receiving placebo, with a statistically significant p-value. Similarly, statistically significant p-values were seen for clinical response, endoscopic improvement, and mucosal healing. If you stratify patients according to prior treatment with TNF inhibitors, you can see that patients who are anti-TNF naive showed higher response rates with regards to clinical remission, clinical response, endoscopic improvement, and mucosal healing, all statistically significant. Now, at week 52, again, the primary endpoint was met. We have 37% of patients receiving the drug developing or demonstrating clinical response versus 18.5% of patients who received placebo, with a statistically significant p-value. Similarly, all endpoints met statistical significance at 52 weeks. Now, when you look at the patients who had received anti-TNF in the past, they did have statistically significant endpoints, but much less than those who are anti-TNF naive. Here's the safety data. As you can see, there's only transient increase in liver enzymes seen in more frequency in the ozanimod arm compared to placebo. Similarly, there is more patients who reported headache. However, there were no serious or severe hepatic injury, no HISLA. Vascular edema was seen in 1 patient during maintenance with risk factors at baseline. It resolved after discontinuation. Frequency of possible, probable, or related serious TAEs was less than or equal to 1% in both groups. Now we have the open label extension data from Touchstone, a previously published study investigating ozanimod as an induction maintenance agent for ulcerative colitis. So in this open label extension study, eligible patients from the previous trials had the option to enroll in this trial to receive study medication until the end of 2021, or until marketing approval of the drug for UC is obtained in their country, or until the sponsor discontinues the development program, whichever comes first. And as you can see here on the right, open label extension extended to week 200. These are some of the measures and endpoints that were followed up during this open label study, including partial Mayo score, endoscopic measurements, clinical response, clinical remission, histologic remission, biomarker response, and adverse events. Now, you can see that 170 of the 197 197 randomized and treated patients on the core study, which is 86%, entered into the open label extension phase. Overall, 58% discontinued the medication during the open label extension. 28% of patients discontinued in the first year. Annual discontinuation rate was between 15 and 18% in years 2 to 4. You can see here on the left side the very nice gradual decline in partial Mayo scores during follow-up up to week 200, and then finally a plateau starting at around week 34. On the right side, you can see the percent of patients achieving clinical response or remission during the open label extension based on NRI analysis. As you can see, at week 200, we have 36.5% of patients in clinical remission and 41.2% in clinical response. So here's a summary of or overview of the adverse events during the open label extension. Now we have 60% of patients experiencing at least one TEAE and 9.1% having at least one serious TEAE. So to summarize, as I mentioned at the beginning, deeper remission is associated with favorable outcome in ulcerative colitis. Histological remission is an evolving outcome that has become a part of treatment strategies where you see treatment with biologics is capable of achieving deeper levels of remission. Treat to target is currently the standard method of treatment for UC. Now, according to the literature I presented, new effective therapies such as anti-cytokines, S1P1 inhibitors, JAK inhibitors, and selective leukocyte adhesion molecule inhibitors are effective and safe options for therapy. Thank you very much.